afternoon, everybody. I will be presenting on, as it was mentioned, on the Ethiopia's experience on home-based newborn care. This will be the outline of my presentation. We will have some background informations and the overview of the health extension program with its objectives, the health extension workers, and the package, and some information on achievements and challenges. As a background, Ethiopia is located in the Horn of Africa, which is the second most populous country in Africa next to Nigeria, with an estimated total population of 86 million, and the population growth rate is 2.6%, and 84% of the population resides in the rural areas. We do have 9 regional regions and 2 city administrations, and the 2011 DHS showed that the fertility rate is 4.8 births per woman, with contraceptive prevalence rate of 29%, and with the skilled birth attendant remained at 10%, with around 676 maternal mortality rate. To look at the trends on the under 5 child mortality rates, the under 5 mortality is progressively decreasing. It was like 166 in 2000, and it reduced to 123 in 2005, and the 2011 data showed that it reached 88 per 1,000 live births, and the target for 2015 is 68. But when we look at the newborn mortality, it was around 49 in 2000, and it reduced to 39 in 2005, but after 5 years it remained 37, which showed for the government to take actions to reduce the newborn mortality rates, so that it accounts for around 50% of the infant mortality and more than 40% of the under 5 mortality. So unless we address the newborn mortality, we will not achieve the MDG4 target. As it was mentioned on the previous presentations, the major direct causes of newborn deaths are preterm, followed by intrapartum related and severe infection. And 25 to 45% of all these deaths occur in the first 24 hours after birth. So to look at the health system tier in relation to the service delivery system of the MCHIP components, we do have a 3-tier system with the health post, which provides service to 3,000 to 5,000 population, and the health center and primary hospital forms the primary level health care, and the general hospital is secondary level, and specialized hospital as a tertiary level healthcare. So the primary healthcare unit is formed by the 1 health center and 5 health posts under the health center. It serves for around 15 to 25,000 population. As you can look at the picture, the 5 health posts are under the health center, and we have around 4 to 5 on average of health centers per district. And we have 1 primary hospital at the district level, which serves for 60 to 100,000 population. Then previously, the services were mainly curative, and it was not addressing the population at the grassroots level. And this was identified in the HSDP 2 midterm review, and the health extension program was proposed as a recommendation from the midterm review. So the objective for the health extension program is to increase equitable access to essential promotive, preventive, and selected high-impact creative health interventions, which targets households at the community level with a philosophy that the right health, if the right health knowledge and skill is transferred, households can take responsibility for producing and maintaining their own health. So it promotes and relies on community involvement, ownership, empowerment, skill multiplication, and self-reliance to ensure sustainability. The health extension workers are grade 10 complete female workers. They are trained for 1 year on health care courses. They are, most of them are female, and they are selected with the participation of the rural community for whom they will provide the service. They are paid based on the payroll. And as it was mentioned, we have 2 health extension workers per 3,000 to 5,000 population. So currently we have over 34,000 health extension workers in the rural community. And we have more than 15,000 health posts. These health extension workers are supported by Community Health Development Army. So this is the pictorial representation of the health extension workers and the Health Development Army and the communities they serve. So in a village, we have 2 health extension workers. Under the health extension workers, there are health development teams, around 30 to 40 per village. And this 30 to 40, each health development team have around 1 to 5 networks. And we have around 150 to 1 to 5 network leaders. And one village has around 1,000 households. So these are the packages which provided by the health extension workers. There are 16 packages are included in the program as integrated manner. The 5 components goes for family health, 7 are hygiene and environmental health, and disease prevention and control is 3, and health education and communication as a cross-cutting component. So to mention some of the activities at the community level as a component of maternal and child health, which performed by the health extension workers to address the 3 main causes of death for newborns. With the prevention of preterm birth and low birth weight is there because they provide the malaria prevention activities, the environmental management, LA lines, and management of malaria. And there is also clean and safe delivery and promotion. They promote also institutional delivery, and they provide essential newborn care as immediate postnatal care. And we have the ICCM, and we are now piloting the kangaroo, the community level kangaroo care. To address the intrapartum related complications, they provide focused antenatal care. They provide 3 cares at the health post level and refer the mother to health center for at least 1 ANC follow-up at the health center level to get the services which are not provided at the community level. And they also promote the institutional delivery, the ICCM and essential newborn care is also there. And to address the newborn infection, they treat infections like malaria, and we now are planning to learn from 6 zones on the community-based newborn care, including sepsis management. So this year will be the learning phase, and next year we will scale it up nationally. The service modality is at household level, outreach, and health post level. So they are expected to spend 50% of their time at health post level and 50% of their time at household and outreach services. To look at some organizational support to the program, as it was mentioned, they are supported by the health center, and this health center is responsible to provide technical and administrative support to the health extension workers during planning, implementation, monitoring, and to replenish also some supplies. So these are some of the achievements and challenges. As you can look at the slide, we would have still challenges on ANC for the immediate postnatal care and skilled delivery at birth and the PMTCT. So we need to strengthen our efforts to address those challenges. Thank you very much.